Hello, everyone. Can you hear me?
Yes, you're audible.
Okay. Welcome to another edition of the SIGAf Urology Symposium. I'm Olanrewaju Amusat. I'm a urology doctor at the Luton and Dunstable Hospital, and I'm the programs lead for urology SIGAf. So today we'll be talking about tips and tricks for the ST3 urology application. And we've been able to get two speakers who were successful at the last application round, who will take us through what it takes to submit a successful application and to also ace the interviews. I can see we've got a full house already, and we're also expecting others. Without wasting any further time, I'll be calling on the urology SIGAf lead, Mr. Yokunle Adenipekun, a urology trainee with the West Midlands Deanery, to give his welcome address. Thank you.
Yeah, thank you very much, Larry, for that introduction, and thank you for arranging this. Hi everyone, thanks for joining us today. My name is Ayo, and I'm glad we were able to make it to another ST3 symposium. I'm sure we can testify that the one we had last year was really helpful, and I'm glad we've brought it back again this year for a second running. So, as you know, the event is designed with us in mind, early career doctors, designed to help us navigate the journey into specialty training. We understand that the journey through specialty training applications can be complex, at times it's daunting. However, we believe as a team that with the right guidance, strategic preparation, and mentorship, it's a path that can be successfully navigated. So today, basically, we are aiming to demystify the process, highlight the key milestones for portfolio development, and provide practical advice for interview preparation. We've got two great speakers today. If you remember well, they were also part of the audience last year, and I'm very glad that they are here to share their experience. So I've got Mr. Habib Abdurrashid, who is a very good friend and colleague of mine. Currently works as a specialty registrar in one of the busiest DGHs in the West Midlands, and is a great chap. He will be giving us the portfolio talk. I've got Miss Anna Apala, who I met when she was working as a urology registrar at a very busy tertiary hospital also in the West Midlands, and they've both been successful in their applications, ranking or getting their top choices. We basically aim to walk through the basics, which is the essential person specifications, talk about how to create a robust portfolio, and we go on to talk about practical preparations for the interview, talk about different scenarios that may come, and how each of these tests different competencies. So together, our speakers bring a proper wealth of knowledge, experience, and inspiration, and I encourage you to fully take notes, prepare questions. This is an invaluable opportunity to learn directly from people who have successfully navigated the path you're about to embark on. So thank you all for coming, and I hope we're going to have a very, very enjoyable afternoon.
Yeah, thank you very much for that very wonderful welcome address. Just to let the audience know that I was also one of the audience last year, and I've also been able to secure a training number, an academic clinical fellowship post as well. So thanks to SIGAf for putting this together. So I'll be calling on Dr. David Akintayo, a resident doctor at the University Hospital Southampton, to read the citation for the first speaker. Dr. David Akintayo, is he there? Let me just check if he's there.
If he isn't there to move things along, I can bring it up and read it. It would be a very great honor to read Habib's citation.
Okay, that's fine. You can go ahead then. I'm not sure he's there.
Let me just look for it and get it up. It will take a very short. Okay. So I will be reading the citation of Mr. Habib Abdurrashid, who is going to be taking us on the Urology ST3 self-assessment and application form part of the talk. Habib Abdurrashid is a specialty registrar in urology at University Hospital Birmingham NHS Trust. He is a distinguished graduate of the University of Ibadan, Nigeria. He was a recipient of several prestigious undergraduate awards, including the Federal Government of Nigeria Undergraduate Scholarship, the NNPC/Total Energies National Merit Scholarship, and the US Government MEPIN Undergraduate Research Grant. He is a member of the Royal College of Surgeons of Edinburgh and holds a certificate in leadership and management in health from the University of Washington. Alongside his clinical training, he completed a master's degree in medical education at the University of South Wales and contributes actively to teaching as a medical student tutor at the University of Birmingham. Habib has authored publications in peer-reviewed journals such as BJUI, Turkish Journal of Urology, and Curious, and he has presented his research at major international meetings, including BAUS, AAU, and ACIT. In 2024, he successfully secured a national training number in urology on his first attempt, achieving 64 points in his self-assessment and his first choice hospital placement. He will be sharing his insights on maximizing self-assessment scores to secure a urology ST3 interview. Habib Abdul-Rashid, you have the floor.
Thank you very much, everyone. Thank you, Ayo. Ayo is video my citation today. It was very much instrumental in securing this post for me, and I thank you for everything I've achieved, to be honest. All right, let me be sure you can see my presentation. Can you see my first slide now?
Yes.
All right, good. Good afternoon, everyone. I'm Habib Abdul-Rashid, and I'll be taking you through the National Urology application, the tip and tricks. Specifically, I'll be talking through the self-assessment and application form and how we can maximize the scores here, getting as high as possible to get the interview that we all dream of getting, and then eventually getting the ST3 number. The goal is just to get this offer, not just an offer, but offer in your choicest hospital. I wanted West Midland, I wanted New Cross Hospital because of personal reason, and that was exactly what I got. So I'll be dividing this presentation into 3 sections. Section 1 is just to explain how self-assessment is very important to everything we're doing. And then what are the key important things in the self-assessment and how to get a very high score. And then what are the tricks that we can all use to get this high point. All right, so the self-assessment is a core and important part of the application.
Sorry, we can't see your slide. Your slides aren't moving.
They're not moving.
Yep. Yeah, we can see. Yeah, slides are moving now.
See now.
Okay. You need to reshare your screen.
Okay, so let me share the whole screen so you just see everything I'm doing then. Okay, so I'll just bring this up now. Can you see my screen now?
Yes.
All right.
Yes.
Can you see it now?
Yes.
Okay. All right, great. So I've said the self-assessment is very important, and it constitutes a core part of the oral application for ST3 Urology. It's a multiple choice questionnaire that has 24 questions. It used to be 23 questions, but a 24th question has been added for this 2026, which is all about how well you've presented your evidence. There's a total of 78 points achievable, used to be 76 points. And this self-assessment constitutes a fifth of the whole score for your ranking. It is very important because without a good self-assessment, you cannot get an interview. And even when you get an interview, a lot of people who fail to get the ST3 job was because they were unable to get to the interview stage. And this was because they could not have enough score for the interview. And in addition to this, most people who were able to get to the interview stage, more than 50% of them will eventually get a slot at it, an ST3 slot. Last year, of about 128 people who were interviewed, 87 of them were appointable for ST3 training, and the first 60 got the offer the first time, and then subsequently the other 27 eventually got one offer or the other. Might not be in their choicest hospital, but they get the offer. Meaning that if you are appointable, you have a very high chance of getting the hospital for your training. And that is why the self-assessment is so important. For this year, the closing dates for this application is 11th of December 2025, meaning that all the evidence you'll be supplying must be on or before 11th of December 2025. All right, moving to the questionnaire itself. It's a 24 questions questionnaire I've mentioned. The first 3 questions will be on PhD, your MD, and thesis, and this constitutes 11 points. Most people will not have this point. I do not have any of these 11 points last year, and I still got 64 points. If you have PhD with orally examined thesis, you'll get 6 points for that, and that's a good way to start. If you have a master's, you have 3 points for that. But if you have a PhD, but you've not had an orally examined thesis, that will just be 2 points for that. And the evidence to supply here will be your degree certificates and evidence of the research which you did during the postgraduate studies. Do not worry if you don't have any one of this. So this is how it was stated in the self-assessment questionnaire. So the second part is the paper publication. This is very important, and 9 points are at stake here. And the question 4 is 6 points, which is being a first author, not co-author, not collaborative author, just first author. You have to be the first author of that particular paper, and 3 of them will give you the maximum 6 points. If you have 1, you have 2 points. If you have 2, you have 4 points, and 3 will be 6 points. In question 5, if you have 2 non-first author paper publication, you might be the second author or the 10th author, or a collaborative author or co-author, whatever author it is called. You just get 1 point for each paper that you submit, and you have a maximum of 2 points for this. For question 6, if you have a remaining non-first author publication, or you have an e-publication, whether you have one in medium.com or GK Medics, which are the area where you can have your e-publication, or you've written a letter to the editor, you have 1 point. You only need one of these to get your 1 point, and that will give you your maximum 9 points. It is very important to know what you need to present as evidence. What I presented as evidence last year was, this is the first page. If you can see, what you have on your left side is the first page of my evidence, and that is to show in 1 sentence what I'm claiming for this point. I'm claiming 6 points for question 4, for example, because I've got 3 papers as first author. You could see that I mentioned the paper title, the journal that I've published it in, the date of my publication, which has to be on this occasion before or on the 11th of December 2025, the DOI and then the PMID for that particular publication. If you don't have the PID, if it's part of the urology green list, that is still acceptable. And if you have a look at the application form, you will see the urology green list. If you click on this this red link, you'll be able to get to the urology green list, and you will see the list of publishers that are acceptable for that. So you need the acceptance letter and the paper itself to submit as evidence. Now, and that's what you need to do for all your publications. The part C will be the audits and QIPs. And the audits, here you have 10 points at stake. Having a 2 closed loop audits or 2 QIPs satisfy to have a maximum of 4 points. And sorry, to get the maximum points for the closed loop, and then another 2 single loop audits. All these audits must be in urology. If you have any audit that is not in urology, I would advise you present that as a presentation, and you get that you get marks for your presentation rather than using it for audit. Because if you have it for urology, you might not get your maximum points for that. So if it's urology based, then you get additional 2 points each for each of them. But if it's not in urology anyway, you get the 4 points for any closed loop and 2 points for single loop if you have 2 of them, and then you lose points for this question 9 and question 10. And that's why just do it in urology. Okay, so there's a new urology audit or QIP supervisor form. Just be aware of that. If you go to the application page, you will get this form, you print it out, and then you get the supervisor for that particular project to sign it for you. So that's all you need to present as evidence. So what I've done during my application is to get a table again, tell them where my evidence are. So I've got 2 audits that I'm using for my evidence. So one, I use my supervisor form and then the poster. So I just, in a way, make all my audits. I make a poster for all my audits as if I was presenting it at a local meeting. You know, when you finish an audit project, you should present at your hospital to have their own input into it. So you can just add the poster you've presented in-house as an evidence as well. Okay, but all you need all you need is just the supervisor form, to be honest. So, but you can just add the poster as an addition. The next is presentation. So to get a maximum points of 10 here, you need international presentation and regional presentation. To be honest, if you can make everything international, that's just good. You can supply evidence, international evidence as regional evidence. That's acceptable. So you need 1 unmoderated international presentation, which will give you 2 points, 2 moderated international presentation to give you 5 points. And for all your international presentation, you can get 7 points for that. And for regional presentation, you need 1 unmoderated and 2 moderated to get 3 points in total. And that will be 10 points in total. The national or international meeting, a lot of them are banned. Can be in the UK, can be outside the UK. But you have to show evidence that it is indeed international presentation. And if it is regional, you provide evidence that it is regional. Things like West Midland meeting, urology meeting, East of England urology meeting, those are regional. The BAUS conference, AAU conference, EAU conference, AAU conference, all of them are international and acceptable. The evidence I provided were evidence that are not from the UK, and they were accepted for me as evidence. So you need certificates, the abstracts, and the conference meeting showing your presentation to get maximum points for this. And this was what I submitted as evidence last year. So for my question 13, which is the moderated presentations, in international presentation, I had 2 presentations at BAUS, and that was what I submitted. If you have presentation at BAUS, you do have nothing to be worried about. All you need to supply to them is just the evidence, the program, which also contains your poster as well, and then the evidence of the place of presentation, which is BAUS. So I submitted all this evidence. Don't mind me, I submitted everything available to me, whether it is relevant or irrelevant, because there will not be any chance to add to whatever evidence you have submitted. You just have to submit all the evidence at a go to avoid rejection. All right, so party, just other portfolio elements, which include your teaching, postgraduate prices, management, and then the way you've arranged your evidence. Question 15 is about your medical teaching. You have up to 4 points to get for being the principal organizer of this course. I will advise everyone to have this because most people will have these 4 points. All you need is organize a course. Might be in urology, might be one surgical related course that will run for 4 hours minimum. So you have your program of events. So this is what I've submitted as evidence for that. You have a look to your left side, you will see my page 1 and page 2 to your left side, containing my first page, which is, yes, as a principal organizer of relevant course, which has run by application date, and I claim 4 points for that. And what I submitted as evidence were the course title itself, which contains all the course elements, including the program of the teaching, the feedback which I analyzed by myself, as well as the attestation letter from my education supervisor. The attestation letter from the educational supervisor or from any consultant is all you really need, to be honest. But in addition to that, to just let them know about what I've done, I just submitted every other thing that I have regarding my presentation, regarding the course which I have organized, and that will be enough for you to get the maximum points. So for question 16, you have up to 3 points for a master's in medical education if you've gotten up to that. But to be honest, you do not need to go all that far. So for question 16, if you just have training the trainer course, which is what most people will really provide, you have 1 point for that. And that might just be sufficient. If you have a diploma in medical education, that's fine. That's 2 points. And that was what I was able to submit last year, because I have not completed my master's as at when I was submitting evidence. So I just had a modular diploma and I submitted that. But you don't have to really apply for a diploma in medical education. It's very expensive. Just do the training the trainer course, and then you have your 1 point, which is what most people will really be able to provide evidence for. Question 17 is about your postgraduate price. What I would say here, to be honest, is about how well you've been able to convince them that it's a postgraduate price. If you have a grant before, a research grant, a research award, or any first prize, you can provide this as evidence. So the common evidence people use will be a research grant that they've won, and that will be accepted. If you have best presentation in any conferences, that is not accepted under question 17. But if you have ever won any award that is medically related since you finished medical school, please supply this as evidence. That was what I did last year, and I got my 2 points for that, to be honest. The evidence I submitted, it was ridiculous to me, but I felt it was an award because it was indeed an award that I got after my graduation. I got one as FY2 equivalent while I was in Nigeria, and another one during FY2 as well. And I submitted it to them, and I was able to convince them that it was indeed a postgraduate award, and they gave me the 2 points for that. All right, for question 18, best presentation. You have up to 3 points for best presentation. You have up to 3 points for best presentation award. So these 3 points, you can get it if you have either international, you have international award, you get 3 points for that. But do not, if you have it in regional presentation, you only get one award for that. You have one award, you have 1 point for that. So what I've submitted as evidence here was an international presentation that I made while I was in Nigeria. I was in the UK, but it was an online presentation that I gave in Nigeria, and I got the best presenter for that. It's classed as international because I was able to demonstrate that many people from across the world presented during this conference, and I got my my full marks for that. All right, so for question 23, leadership and management, you need to demonstrate whether you've been a rota coordinator for about 6 months, for 6 months at least, or you've been involved in medical management in any capacity. In my own case, I was a deputy urology lead for SIGAf last year as well. I'm still the deputy lead now. So I presented that as evidence, and that was given to me as a leadership award. And then as well, I also got rota coordinator for 6 months, and that was enough for me to get my points for 23. And then for question 24 is how well you've arranged your evidence. This is a new one, and that shows that you need to really arrange all your evidence in a way that it is very easy to really follow. And I'll show you an example of that just before we finish this presentation. All right, so for the part F, surgical logbook, question 19 to 22, almost everybody will get 20 points here. You cannot afford to lose any marks from these 20 points. Ensure you get your 20 points here. It's a free 20 points for all. All you need to do is show evidence that you've signed by 2 consultants. We've asked this question severally last year, if one consultant can sign on 2 occasions. And why some of them have said it is acceptable, others have said you need to get this from 2 different consultants. If you're able to get it from 2 different consultants, that's acceptable. Get it. If it's just one consultant that will sign you on 2 occasions, provide this as evidence. The worst case scenario is that they probably reject one of them. I don't think they will reject it, to be honest. Another question people ask is if locum consultants can sign you off for this surgical logbook. Yes, they can. I've used locum consultant as part of my people that have signed for me, and they accepted it for me. So for index procedure, cystoscopy, which can be rigid or flexible cystoscopy, ureteric stent insertion, scrotal exploration, whether it is for hydrocele, testicular torsion, or any scrotal operation, you just have your points for that, and then circumcision as well. So if you have level 4 evidence, whether it is 4A or 4B on ISCP, and you have 2 WBAs, which can be DOPS or PBA on ISCP as evidence for that. So you submit that as evidence, and that will be accepted for you. In addition to this, you also need to submit evidence of this procedure in your e-logbook. Some people last year have submitted evidence with their DOPS and PBA, but they did not submit e-logbook, and they got 0 points for this. It might sound callous, to be honest, but you don't want to miss out on this. So it's very, very painful that you have to appeal for you to get your points, even when you already demonstrated that you have DOPS and PBA for this. So just look for the e-logbook, print it out, get a consultant to sign it, and that's all you need to get your points here. So please, your WBA as well as e-logbook evidence should be submitted as evidence here, please. And that's what they've requested for. Okay, so what I have done here again is to give them a table for cystoscopy, for example, rigid cystoscopy, WBA evidence. I used my DOPS for my WBA, and then I also provided logbook evidence for the procedure. And then I got it signed by my consultants to get my point. So that's all about question 1 to 24 for the WBA. So how do you upload this? How do you answer this question on oral? I've made a, so what we need to do is that by the application for this year will open November 20th, and it will close by 11th of December. You have 7 days to upload the evidence. After the closing dates, you have seven days to upload your evidence. And then this evidence has to be arranged serially, question 1 to question 24, and a single PDF file for each of the questions. If you do not upload a single PDF file and you try to upload more than a single PDF file, you get 0 points for that particular question. So this is the way I've prepared my evidence for every question from question 1 to question 3 and 23. I got each of them have a PDF, and I provided evidence for all of them. All right, what you want to get at the end of the day is that, oh, thank you for your application. Your self-assessment is complete. You get this email, and then they'll send you your score from your self-assessment, and you can either appeal or you go ahead with it. All right, so this is a short video on how you apply for the ST3 on oral. So I just explain as I'm playing the video. So the first thing you do is you go to oral, you register with oral, you put all your CV, you upload it there on oral platform, and then when the vacancy is open for ST3 application, you basically just type urology ST3 urology ST3 on the search box here, and then you will see this. So you see it now. So this is what you will see. Oh, sorry. I'll just play it again. So you type the urology ST3 application, and then it will, I'm trying to, because this vacancy has been closed, the 2024 vacancy is closed, so I have to go to the closed vacancy to see my last application on Oriel, and that was what I was trying to do here. So you have both LAT as well as ST3 application for last year. So that's what you will see there on Oriel. So once you get that, then you go to the application. So I was trying to go to the application here. So these are the application documents. That's your CREST form that you need to upload as part of the application. So the form, I'll go to the form now. So application form. So it's just trying to navigate to the application form. So you have your personal information, you upload your personal information on the application form. That's your part 1 for the application form. Then the part 2 will be the real application form itself. The part 2 will be your training history, your references. You get everything uploaded there. Then the supporting information, which is the important one, and then the self-assessment one. Sorry, which is the supporting information will be your MRCS Part A and Part B. If you have certificates for MRCS, you get that done. So this is how you'll be answering the question. You can see the question 1. They ask, how many of the following qualifications have you been awarded? Peer-reviewed thesis, PhD. I just click 0 because I had nothing there. Then moving on, have you seen the paper publication? That's paper publication there. Then they ask you a question, how many of these did you have? I tick 3 or more to be 6 points, and that was what I ticked. So basically just tick one of these 4 options, and I just tick 3. And that's how you answer all the questions on Oriel application. So you just basically tick them. There are multiple choice questions. You tick the one that applies to you, what you are claiming. You tick, so this is at presentation level. And then they ask first author poster presentation unmoderated. I said, yes, I have 1 or more. That's 2 points. Unmoderated regional. I said, I have 1 or more. I tick that. And then that's how you do for all the other components. Postgraduate medical training, medical postgraduate prices, surgical logbook, you take it as well. Medical management role, you take it as well. So you're basically just going to take the self-assessment on Oriel, and then you just go ahead and then you submit. And that's just everything on Oriel. That's all you need to do on Oriel, and that's just that. Then the next thing will be, so I was just trying to show how the application form looked like for if you are using the alternative certificates for eligibility evidence. So if you don't have the CREST, if you don't have your CT1, CT2 training here in the UK, and you just want to use the alternative certificates for eligibility to enter higher surgical training, this is for 2026. So you should look for 2026 form, and that's what you need to sign with your supervisor or your consultants. Why I have mentioned this here is that last year when I applied, there was a part of the form which I did not tick, and my application form was rejected for that. And this was where I have highlighted with love here. If you have a look, there are some areas here where you need to tick, where your consultants need to tick. These boxes, 1, 2, 3. They need to tick those boxes, put a stamp here, sign here, and put their initial here. So all the signature for all these questions you are seeing, it has to be in the consultant's initials, not just signature. They write their initials there as a form of signature. So please remember to tick these boxes. Tell them to tick these boxes. I did not take it last year, and I just got their email that my application was rejected for something. I'll just show you that now. So imagine they just sent me this and they said that, oh, they've rejected my application because I did not do the appropriate thing. So this was what they put at the comments. Signatory has not completed their 3 declaration ticks. You have a look here. So missing tick on declaration page. So that's very important. Ensure that you complete all the parts of the form before you submit them. And that's very important. So the tip and tricks. Start very early. Start gathering your information from now. Get all your information or all your evidence ready. Start preparing for everything now and show it to people who have applied before so that they can share their experience with you and tell you whether the evidence you're providing is sufficient or not. It will require you to be converting from Word document to PDF, from PDF to image, and then compiling everything together, converting into PDF again. So you need all this PDF editor to be slicing PDF, cutting it, pasting, joining, cutting, and everything. You require all those experience to be able to submit as appropriate. Then ensure that you read the new 2026 National Urology Handbook and the Self-Assessment Guidelines. They're a bit different from what used to be. Do not just, especially for people who have applied before, do not just assume that what used to be is what is still. Read it again, ensure that you're providing the appropriate information and that you answer the right question. You're answering the right question. Be very honest. Give all the evidence you have. Do not falsify evidence. Evidence that you'll not be able to get backing for, please do not supply it. As this can lead to removal of your recruitment as a recruitment process or even referral to GMC. I would say you aim at getting 57 this year or even more than that. Why I say so is because last year the cutoff point was 53, though few people who had 52 points were able to get the interview. We don't know the criteria they use to select the few of them. I think the idea is for them to be able to get about 128 people who will be interviewed in the course of the 2 days. So if they, for instance, if they are at number 115 now, and the rest of the people have the same points, they'll just probably select the remaining 13 people to make up to 128 because I think they will not exceed that particular number for interview. So ensure that you get a very high score, aim high, get high points, and that will help you in 2 ways. It will help you to secure your interview slot, and it's also help you at a station because the interview station itself, the first station are just 4 stations, and this portfolio is just a 5th station if you see it like that. So it's 20% of the whole marks, and the interview is the 80% of the bulk. So provide all the information that you have, all the evidence you have, provide all of them. And that's the way to go about it. And I wish everyone the best. Thanks so much to SIGAf for giving me the opportunity. Thanks to Ayokunle Adenipekun. This is the man who showed me the way last year when I did not know anything to do. He showed me, oh, this is the right place to publish. This is the right way to really present your evidence. And that was really helpful. You also need your supervisors to help you with your signature and how to get your maximum points. Thank you, everyone.
Thank you so much, Habib, for the very beautiful presentation. Thanks for sharing from your wealth of experience with the application. I'm sure we've all learned a lot from your presentation, and I know there'll be lots of questions. So what would happen is we'll take all the questions after both and then some people have asked me certain questions as well. So all questions will be taken at the end of the second presentation. So thank you so much once again, Habib, for that very lovely presentation. We'll go ahead to the second presentation for today, which would be delivered by Ms. Anna Akpala, a urology reg in West Midlands and also an incoming reg in London. However, I would be calling on Mr. Mayowa Adefeyinti, Urology SHO in Peterborough, to read a citation. Mr. Adefeyinti.
Hello. Good afternoon, everyone. I'll be reading the citation for Miss Anna Atmala. So Miss Anna Atmala works as a urology registrar at Queen's Hospital, Queen Elizabeth Hospital, Birmingham, and she's an incoming ST3 trainee with the North Central and East London Deanery. She obtained her MBBS from University of Port Harcourt, Nigeria, and is a member of Royal College of Surgeons of England. She began her urology surgical training as SHO in Queen Elizabeth Hospital. She currently works as a senior clinical fellow in University of Birmingham, Queen Elizabeth Hospital. And Anna has published several first author papers, peer-reviewed, and she has published papers in peer-reviewed journals and has a strong interest in surgical education, mentorship, and evidence-based practice. Alongside her medical career, Anna has distinguished herself in pageantry during medical school, winning Port Harcourt University Medical Student Association and Miss Uniport, and Most Beautiful Girl in Port Harcourt, as well as placing herself as first runner-up in Miss ECOWAS and Nigeria pageantry. These experiences has earned her confidence, leadership, and public engagement, qualities she now applies in surgical mentorship. She's passionate about equity and representation in surgery, particularly for women and internationally trained medical graduates. Anna is committed to inspiring the next generation of surgeons. If you welcome with me, Miss Anna Akpala.
Hi, thank you very much for the introduction, Mayowa. So I'll just continue from where Habib finished. I'm just trying to share my screen. I have this opened already. I don't know what's happened. Just give me a second. Oh gosh.
Have you seen the share your screen icon?
Yeah. So I need to have the window open. I thought I did.
Okay.
Let me try again. And then if I go back, no, not that one. Sorry, guys. I did a practice run yesterday just to avoid this, so it's a bit embarrassing. It's happening. Let me try.
No problem. Take your time.
I don't want to share whole screen. So I'm going. Right. Can you see my screen?
Yes.
Okay. So yeah, just tips and tricks for the interview, and I'll be going through that using this outline. Now, a disclaimer. The reason I'm giving the disclaimer is because we're not allowed to talk about the stations from the interview. So any stations or examples that I'm going to be discussing today are not from my interview. They are from courses, mocks that I had with my consultants. I have no affiliations with any resources, websites, or books or YouTube channels that I recommend, and I have no conflicts of interest to declare. So the ST3 interviews used to be in person pre-COVID, but since COVID, it's now been virtual in the form of like Microsoft Teams. It lasts about 60 to 90 minutes. You have 4 stations, and each station runs for about 15 minutes. So you have 2 minutes to read the question, the VignetNet, and then you have 30 minutes to answer the station. There may be a bit of a time lag in between stations, just so that the examiners score you. And so the time it takes for you to move from one station to another, you may have to wait a few minutes, but it's done automatically. You don't need to do anything. Now, on average, you'd have 2 examiners in a station, plus or minus 1 observer. And again, this took me by surprise. Some of the examiners' videos were turned off. So just so you're aware. You may also have just 1 examiner in the whole station, no observer, nothing. Again, that shouldn't surprise you. I was surprised. Part of the things you may come across would be images. They could put an image of, for instance, a resectoscope in front of your screen and ask you to list the parts, or surgical instruments and ask you to name each of the surgical instruments. Or it could be a CT scan image and you may be asked to describe what you can see. Again, no surprises. So the 4 stations are outpatients, emergency, skills, and communication. Now for the outpatients, again, it's what you do day to day, clinic setting in an outpatient clinic. It could be a general urology clinic, it could be a testicular clinic, a stone clinic, or functional urology clinic. You would often be told in the VignetNet. Now you need to know where you are. You need to know who is with you, is your consultant with you. It will also be on the VignetNet. Sometimes they may say your consultant has been called to theatre. There's a reason you've been told. So you have to be present to know what has been said, because you would look foolish if at the end you say, oh, I'm going to go next door to discuss with my consultant, but you were told the consultant's not there, and you'll be marked down for that. Again, it's important to be a super reg. So essentially, you should be able to request or do what can be done in an ideal setting, but it should be realistic. So for instance, you're running a BPH clinic, you can get urinalysis on arrival, you can do a flow rate, post-variable schedule. These are things that can be done. If it's a testicular clinic, you could also get a same-day testicular ultrasound scan. So again, even though in the NHS, it's not often, you don't 100% get this all the time, but in an ideal world, you should be able to. And so imagine you are a super rich, you have everything at your disposal, but be realistic. That's the key. So for the outpatient scenario, again, you would follow the usual steps. You take a history. If you see a patient in clinic, you read the referral letter, you take a history from them, you would examine them in the presence of a chaperone, and then you request for some investigations, and then you would discuss treatment options. So again, for any medical condition, always provide treatment options. Even if you would recommend surgical treatment, always provide, oh, there's a medical treatment, there's a medical option, and then there's a surgical option. That puts you on a higher level than someone who just comes and says, oh yeah, you've got BPH, it's TRP, compared to someone who would then talk about minimal invasive versus non-minimal invasive options. So examples of the stations you might see for the outpatients include raised PSA, LOTS, testicular lump, it could be phimosis, recurrent UTIs. These are some of the common ones that you could come across. Next is the emergency station. So for the emergency station, it could be a prioritization scenario or a non-prioritization scenario, where for the prioritization ones, you might be given 3 acute things going on at the same time, and you'd be asked how you'd manage. There may not be a right or wrong answer, provided you can explain why you would attend to this before this. So you might be given a station where, oh, you've just been called from the ED. There's a 14-year-old chap with 4 hours history of acute testicular pain. whilst on your way to ED, you get another call from the gynae theatre. There's a 45-year-old lady undergoing a difficult hysterectomy. They think they may have injured the bladder. Oh, and also you get a call from the ward. There's a patient who is post-op day 0, and it's spiking temperature. Your consultant is at home. You've got one lovely CT1 with you. How would you manage? So a prioritization scenario, they want to see how you are going to triage these 3 patients, how you are going to delegate. They want to see that you're a team leader. You know that for a suspected bladder injury, this is not something as an ST3 I can manage. So I'm going to speak to my consultant to kindly come and attend to this patient, but I will tell the theatre team to get this, and this ready for the consultant. And I will ask my SHO to see this post-op patient because I'm worried that the patient in ED could be testicular torsion, and I have to see that one myself as they may be going to theatre. So that's what a prioritization scenario may look like. A non-prioritization scenario could be just simple, 70-year-old male hasn't passed urine for 8 hours, he's in a lot of discomfort, ED are not able to pass the catheter. How would you assess? So again, that's just plain simple emergency scenario that we see every day. So key things in the emergency scenarios, things like sepsis 6, you need to say them out loud. Even if you're doing them, you're saying, oh, I'm going to take bloods for FBCs, UNE, CRP, blood gas, or start him on IV fluid. You need to say, I would manage this patient using the sepsis 6 protocol, or I will assess this patient using the CCRIS protocol. If it's trauma, ATLS, according to the multidisciplinary approach, you have to say these keywords. When you say them, you set yourself aside from every other person that just blabs A to E. Setup, okay, you need to know where you are. Are you in ED? Are you in SHO? Who do you have with you? What time of day is this? Very important. They often put that in the vignettes. It's important because there are certain things you can't get at 11 p.m. whereas you can get lots of help if it's during the daytime, even if your consultant is stuck doing an nephrectomy. So some of the examples are testicular pain, as mentioned, retention, Fournier's gangrene, and could be sepsis following PCNL, following biopsy, could be TR syndrome. Okay. Now, other things to note in the emergency scenarios, they might require you to take the patient to theatre. So things like how you book on CPOD, you have to speak to your consultant, you have to consent and mark the patient. When was the patient's last meal? Speaking to the anesthetic consultant as well. If they need a DNAR, if you need to speak to the next of kin, these things are important to know. And of course, discuss with your consultant. So in terms of last meal and fasting, sometimes they throw a curveball where they say, oh, this 14-year-old male just had a pack of crisps an hour ago. The anesthetics SHO is not comfortable putting this patient to sleep. What would you do? So you know it's testicular torsion, time is of the essence. You can't wait for the patient to fast for 6 hours. So you can suggest a rapid sequence induction by their senior. You can suggest it politely. Again, this is something they want you to be aware of. So moving on to the skills stations. I like the skills stations because it's something you do every day. It's most likely going to be one of those procedures that Habib talked about in the your surgical logbook session most of the time, or maybe one or two other skills not there, like TRBT therapy or orchidectomy. But it will often be something related to that logbook, which most of you would have seen and done. So you might be asked to describe a procedure or how you would brief for a case. Again, remember how we do it in theatre. Imagine that you're in theatre when they ask you these questions. You talk about who checklist, positioning, antibiotic prophylaxis, and VT prophylaxis as well. And then they might bring in consenting, how to consent a patient, to make sure you talk about BOWS leaflet and trust information leaflet, because it's on their marking scheme. So if you just talk about BOWS leaflet without trust information leaflet, you may not get all the marks. And again, talk about marking if it's relevant. And then, like I said, they might ask you to list the instruments or equipment. So if you know the exact equipment you need, or size 3 Vicryl 3O rapid, or you know it's a 10-inch blade, say it. You don't lose any points for saying it. If anything, you get extra points. But if you don't know it or you're not sure, you can just be generally correct. Okay, and then again, where is your consultant? There's always a curveball. You might be asked to do a TRBT, and then they tell you, oh, you've perforated the bladder. What would you do? You stop, and then you call for your consultant immediately. That's what they want to hear. So I've given some examples, how you'd consent a patient for radical orchidectomy, how you'd write the op notes, post-op instructions, etc. And then the other procedures on that Habib's logbook. Now, communication, I think this is where most people struggle, but if you nail it, then you would score really high in the interview, because they don't necessarily test your knowledge. They're testing how you communicate, your empathy, and they want to know if you know your limits, if you're creative, with addressing the patient's concerns essentially. So in this station, the patient might want to keep talking, just let them talk. And the fact that it's a virtual interview makes it a little bit difficult. So it's all about your body language, how you're listening, how you're nodding. So you want the patient to feel that you're listening to them. You want the interviewers to know that you're paying attention. So the patient has said something, you don't want to ask the patient that question again. So you have to actually be listening, show empathy. And it might be a difficult station where the patient is angry, they want to speak to your consultant, they keep going, I want to speak to your consultant. You have to remain calm at all times. It's not real, it's a simulation, so you have to be calm. Even if the patient is starting to be aggressive, you just remain calm. Try to calm the situation down. If the actor sees that you're not falling for their tricks, then he'll just give up, and then it will now be a conversation. So know where you are. Is this an award round? Can you ask one of your colleagues to come with you to speak to the patient, or the nurse in charge? Or is this breaking bad news where you need to have the CNS present or the patient's relative with them? There are keywords here that you must throw out. So things like M&M, you're going to put a date text. This will be discussed in a root cause analysis meeting. You will take a personal responsibility to come back to let the patient know the outcome. Oh, you're really sorry for what they've gone through. Anyone in their position will feel the exact way they feel, just empathy. Talk about clinical governance, PALS, duty of candor. Even if you're having a duty of candor conversation with a patient, you have to say the word duty of candor, otherwise you'll be marked down. I've seen someone's previous feedback form, and she was marked down because she didn't say duty of candor, even though that's what she did. But you have to say, I will have a duty of candor conversation with you, or whatever. You can see it in your summary. So examples are a lost specimen following radical prostatectomy, wrong side operation, breaking bad news, a patient who's been cancelled from the theatre list, or misdiagnosis. These are very common scenarios. So preparation. Now you've been told how to get everything ready for your portfolio. Do you want to wait to be shortlisted before you start preparing, or do you need to start preparing now, or have you been preparing already? Obviously, the earlier you start preparing, the better. Okay, so I would suggest at least 6 months of studying, because you need to build your knowledge base. You could use the FRCS Red Book, the Oxford Handbook, the Jack Bonatti Urology book, just to know everything urology. You're already doing a urology job, so might as well. You don't lose anything by building on your knowledge. And then practice. So don't wait to be shortlisted before you start practicing for the interview. I would suggest as soon as you submit your evidence, or as soon as you submit your application, you start practicing. Like Habib said, if you know you're scoring, say 55 and above, or 57 and above, you're likely going to get into the interviews. So you might as well start preparing. You can prepare in large groups, or in smaller groups. You practice with your consultants, your registrars. You can get a practice buddy, just somebody that you practice with regularly, but you could also belong to other groups as well. It's very helpful, because lots of information, you learn a lot from different people. You see people's mistakes, you learn from it. You pick up how they speak. As IMGs, we often struggle with communication. So again, what I did was I found someone who wasn't an IMG and made that person my buddy because I wanted to improve my communication. And then I belonged to other groups where I felt they were much more intelligent than myself. And so I was also learning from them, building my communication with this other person who was an IMG. So yeah, again, consultants, I can't say this enough. Practice on whilst on call, in clinic, just do one station with them. Wherever, even with your registrars, your colleagues, I did a few with my colleagues as well. If you're doing a procedure in theatre with an SHO, you can talk them through the procedure that you're practicing. And of course, courses and question banks. So there are lots of courses. Unfortunately, I didn't get into many of them. But the ones I did the Bowles Core Urology course. It's not an interview course. It's just a course to give you basic urology knowledge, but it's really good because it's focused around what an ST3 should know. And some of the faculty are involved in the urology interview, so they tailor their teaching to that as well. And also at the end of that course, there's mock interview, I think one-on-one, where you're given a station and then you're scored on that. And the BSAT interview course, I wasn't able to, sorry. The BSAT interview course, I wasn't able to get booked on that one. But there are lots of courses, they get filled up really quickly, so it won't hurt, just that they cost a bit expensive, but it's worth doing. So the question banks, there's MedSets, Medibody. So I did the Medibody one, my body did the MedSet, so we sort of combined both. Whether they're useful or not, I think they're useful in giving you common stations, but again, you still have to fine-tune whatever information you gain from those. Then what I found really, really helpful were the YouTube videos. So the FRCS YouTube video, where you have lots of doctors who are preparing for FRCS practice stations, I found it extremely helpful because I could listen to them on my way to work, on my way back. They often had structure on how they answered questions at FRCS level, and it was really, really good. And then someone told me about this Urology ST3 YouTube video. If you just search Urology ST3 YouTube on YouTube, I can't remember his name now, but he was he was successful at his ST3 interview. So he recorded a few sessions, mostly from Medibody and MedSet, but he added some information from the FRCS Red Book. I found that really, really helpful as well. So now you've been shortlisted for interview, you need to book your interview. There are slots, morning and afternoon sessions, I think. Again, choose what works for you. I would suggest obviously taking a few days off prior to the interview as study leave if you can, but on the day of the interview, you should request that as professional leave. So you don't use up your study leave on that day. It's professional leave, and that's fine. If you're on call, make sure you do swaps. You cannot be doing this interview while on call. It's not possible. Now, location. So choose where you want to do the interview. Do you want to do it at home? Do you want to do it in the hospital, like in your education center? Book a room beforehand. Test the Wi-Fi there multiple times. Whatever location you choose, make sure it's working, it's reliable. And then your dress code is very important. I would suggest dress corporate from head to toe, including shoes, because it is an exam. So you want to be in an exam mode. So you want to, if you're a male, you want to wear your tie, your shirt, trousers, and shoes. Even if it's in your bedroom, you want to be in exam mode. You don't want to put on boxers and then for some reason you stand up and then you see you. That won't be nice. Even if you don't even stand up, but dressing up completely puts you in that mood and you're ready to smash it. Again, your camera setup, so it needs to be at eye level. Mine's not eye level, but it should be at eye level, and you should be looking at the camera all through because that way you maintain eye contact. And make sure it's well lit so that they can see your face. Your phone should be on silent, but it can be next to you, because if you run into internet issues and they need to contact you, they would contact you through your phone, and they would tell you this anyway. And then sort out childcare. I had a do not disturb sign on my door at home, because I didn't want anyone delivering any Amazon package or whatever. Okay, so I'll talk about pitfalls. Again, many people fail to prepare. They're waiting to get shortlisted first. By the time you get shortlisted to booking the interview, it's about 2 to 3 weeks. That's too short to prepare effectively for an interview, in my opinion. So I would say start preparing early. You don't lose anything by preparing early. Internet issues, because it messes up with your confidence, you're jittery, you're worried, oh God, my internet is down. Eventually you get it back up. It's messed up your psyche already, and you don't need that. And then you made a mistake from one station, or you were prompted in one station, you're worried, oh, I'm not going to get maximum points, and you're worried about that. You carry that into the next station. Again, you're likely to make mistakes. Now, keep it simple. Some of us have been working as registrars for many, many years. So you're very experienced. But for the interview, you are ST3. So you need to remember that. Just keep it simple. Just what someone who is an SHO needs to know, essentially. Okay, don't assume. Say things like, if it's a surgical procedure, don't just assume, oh, yeah, so patients on the table, what would you do? Yeah, so you talk about the positioning, you make sure you say, oh, I'll ensure that whole checklist has been done. Even though they've told you the patient's on the table, what are your next steps? You say, I'll make sure the whole checklist has been done, the patient's adequately positioned in lithotomy position or whatever. Say those things, okay? And then mention your steps or instruments as you go along if you know them. It's good practice. So if you know it's a 10-inch blade, like I said earlier, why not say it? And then also make sure you discuss with your consultant, because again, you're ST3. Don't worry about prompts. Prompts just mean you don't get maximum points. That's it, nothing else, but you still pass. So I know you want to get maximum points, but if you get prompted, don't worry so much. And sometimes what you thought was a prompt wasn't. And again, don't worry about that. And then explain your thought process and management plan as soon as you can. This one took me by surprise because it was in my emergency station. I wanted to finish the station quickly. I wanted to get to the end. And they asked me a question, would you do upper tract imaging? I just said no. I knew why, but I just wanted to move on, get to the end of the station. I didn't want to get caught up with time. And then at the end of the station, I was told I had finished before time. I could add whatever I wanted. So I came back to explain why I said I wouldn't do upper tract imaging, but I was marked down for that. So if, you know, explain your thought process as soon as you can, and don't wait till the end like I did. So I'll just go with a few examples, and I'll try to be as quick as I can because I know we're running late. So for a skill station, you'd have 2 minutes to read the station. It just comes in front of you and you see the timer, and then you read the station. So you are the registrar on the general urology list. You have a 34-year-old male who's coming right hydrocele. He's had multiple episodes of ochitis. He's had an ultrasound that's shown it's a big hydrocele, 8/10, but the testis was normal. And then that's the end. So you have the rest of the 2 minutes to make a note. So what do you want? What you have, you can have a sheet of paper and a pen. So what do you want to note? He's 34-year-old male. What side? It's a right-sided hydrocele, normal ultrasound, 8/10. What do I want to know whilst prepping for the case? I want to know what their past medical history is. Are they on any anticoagulants? Are they diabetic? Things that may affect your procedure, right? What else do you want to know whilst prepping for the case? You think whatever you think is relevant, you just make a note of it. And then if you still have time, you can make a note of some of the equipment that you know you would need. And then the station comes in. The first question is, what's a hydrocele? So you have to define a hydrocele. Simple collection of fluid around the testis, fine. Then they ask you, how would you consent this patient for hydrocele repair? So like I said, you should go back to how you prep for the case, because if you just go on to to stating that, oh, you would consent them using bowels and patient information leaflets. You might miss out on anything if there was anything relevant whilst prepping for the case. In my own situation, it was one of my mocks, it was inguinal orchidectomy. So I just went ahead to consent the patient, but I lost marks because I didn't talk about tumor markers. So yeah, so if you think there's anything relevant whilst prepping for the case, I think you should mention it. So yes, so you would consent the patient using visual and audio aids, using the bowels information leaflet and trust information leaflet. On the consent form, you write hydrocele repair. The intended benefit is to drain the hydrocele fluid, relieve them of their symptoms, the risk associated with the procedure, so bleeding, pain, infection. If you know the percentage, you list it. If you don't know it, just wrap it out as I'm doing. And then other procedures that may be required on the consent form may be a drain. Okay, and then you sign the procedure to be done on a GA, and then you give the patient ample time to ask questions. And if they have no questions, they would sign the consent form. You put a mark on their right hand, and that's it. You've done the consent, yeah? And then they would ask you to talk them through the procedure. So again, don't just start off from when you're making the incision, start from the WHO checklist, positioning, antibiotics, prepping, draping, and then you wrap it along. So you're going to make your incision on the right side, or you can do median raphe. It's up to you, whatever you're comfortable with, whatever you know, whatever you've seen done. Okay, you explain how you're going to do it. 10-inch blade, you're going to use diatony to develop the plane. You're going to use 2 small clips to hold the tunica, and then make an incision, suction the hydrocele fluid, measure the volume, extend the incision, deliver the testis, examine the testis, excise the redundant sac, blah, blah, blah. You talk about if you're doing Lord's glycation or jablate, whatever. And then you talk about whatever suture you're going to use. I'm going to use 2 ovicryl or whatever. If you know it, say it, okay? And then you do hemostasis, and then you close the wound, right? And then you talk about drain or no drain if you want to. And then you talk about the whole checklist at the end, and then you write your post-op notes, and then they would ask you what would be your post-op instructions. Okay, you could say with the aid of a leaflet, I would advise the patient to do this, no showers or baths, no heavy lifting, blah, blah, blah. Okay. And then they might ask you other questions that may be related to hydrocele or not. And there might be a curveball. That patient comes back a few days later with something that sounds like an infection. What would you do? Again, there's always a curveball. It's hardly ever a straightforward station. And so just be prepared for that. So moving on to the emergency scenario, similar. Again, 2 minutes reading time. You're the registrar on call, and it is 11 p.m. You have a 45-year-old male who is 6 days post right hydrocele repair. He's coming in with scrotal swelling and pain. He's pyrexic. So you're making your notes. 46-year-old post right hydrocele repair, pyrexic. What could it be in your head? You're thinking, is this an abscess, a collection, recurring hydrocele? What, you're wondering what it could be, what investigations you would do, FBCs, UNA, CRP, blood gas, query ultrasound scan if you can, but it's 11 p.m. These are the things you make on your notes so that you don't forget. And then 30 minutes, you come into the station. They ask you, what are your differential diagnoses? So you have to have a strong opening gambit. Now, this is a 46-year-old man. Your opening gambit can be you rephrasing the question. So this is a 46-year-old man who is 6 days post-right hydrocele repair, coming in with scrotal swelling, pain, and is pyrexic. I'm worried that this patient could be septic from an abscess, a collection, or whatever else comes to your head. And then within your opening gambit, you've already mentioned some differential diagnoses. So I will go and review this patient myself in ED because it's an emergency. Always say that I will go and review myself in ED without delay. And then, but before I get there, you would have looked at the up note, because that's what we do. Look at the up notes, see the indication for the repair. What was the size? Did they leave a drain? When did the drain come out? Were there any complications? Did the patient go home with antibiotics? Are they diabetic? Is there any reason, anything that would have put them at risk of having an infection, you know? And then you've gotten to ED now. You can see the patient, secret protocol, A to E. You can just say A to E because it may not be relevant, or you can say airways pattern, breathing, blah, blah, blah. Again, it's up to you. And then you take a focused history, you see what you're looking out for. You ask them about their last meal because they might be going to theater, and then you do a chaperone examination. Always say chaperone examination. And then investigations, which we talked about, some blood urinalysis, and then an ultrasound test is if possible. They would then ask you, why do you want to do an ultrasound test? It's because you want to check if the testis is viable, isn't it? Because that would affect what you consent the patient for. And then because you think they're septic, you start them on antibiotics according to TROS guidelines, or you can even say sepsis 6 here as well. Now, you're also going to discuss with your consultant, remember your ST3. You're worried that this patient has an abscess and you think they need to go to theater, you need to discuss with your consultant. So you'd consent the patient, book them on CPOT, speak to anesthetic team and CPOT coordinator. They might ask you what would be on the consent form. So you would say scrotal exploration, washout, right? Plus minus orchidectomy. Very important. That's just higher thinking. Okay, and then communication. Again, it's, as I explained, it's all about empathy, how you can communicate to the patient. So in this case, you're the registrar on call, you have an SHO with you, but they're busy on the ward. You've been asked to review a patient on the elective ward. She's 45. She had left URS today with stents for kidney stone. She's complaining of pain on the right side. So you're wondering, why is this patient complaining of pain on the right side? They tell you her obs are stable, and in the history, she has right kidney stone. She was planned for a right URS, but a left URS was done. They didn't find any stones, so they've left a stent on a string. Now, there are lots of things going on here. So in your notes, you already know this is a wrong side operation. So so she still has pain on the right side. She's had a left-sided operation that wasn't needed. What am I going to do? What are the key things to note here? So you would have looked through the up notes and images, and you'd have assessed the patient, and then you would go to assess the patient. So you'd have a patient on your screen who is an actor, and she might be whining in pain. Oh, doctor, I have pain on my right side of my tummy. I don't know why. I've had this pain for many months, and that's why I came to hospital for this surgery. Why is the pain still there? Why isn't it better, doctor? Can you tell me what's going on? And then you have to break this horrible news that they've done the wrong side operation on this patient. How do you go about it? You weren't even in theater. So this is just what you're seeing on the up notes, isn't it? So it's very tricky. So you have to take a bit of history from the patient, but of course you offer analgesic first, just to make them a bit comfortable. And then you ask them how long they've had this pain. What do they know has been happening? What was the size of the stone? Were they marked on the right side? You know, and then you would have looked at the CT images yourself just to make sure that you have all the information, you have all the right information in front of you. And then you would calmly explain that you weren't in theater, but you've seen the up note and they did a left side operation. You're not entirely sure why, although they didn't find any stone on the left side. They've left a stent on a string, which will come out in a few days. I'm really sorry that this has happened. I don't know why it has happened. It's a never event. This should not have happened, but I will personally discuss with the consultants. We'll carry out a thorough investigation to find out why this has happened. We take these things seriously. This will be discussed in our M&M, all that jazz. We talk about it. Okay. Now, most people get carried away with all them M&M, clinical governance, PALS, blah, blah, blah. They forget the main issue is that she came in with, she still has pain on the right side. So she still has stone. She still has a stone in her right kidney. So you need to think of how to solve her problem. So you might ask her, what's most concerning to you now? And the patient will say, I want to get rid of this stone on my right kidney. Then you have to think of how to solve that problem. Are you going to put her on a CPOD list? Is that a realistic thing to do for an elective case? No. So things like, I will speak to the consultant, we'll get you on the next elective list as soon as possible. We would make sure that you're priority on the list so that there's no cancellation. This is something that is achievable. And that's something you can offer the patient. Saying you're going to put them on CPOD, I don't think that's realistic, and I don't think you should offer that, even though you want to get them sorted on disadmission. Okay? And then you would often have a timer, and sometimes the time may not be enough. Once you get the 1 minute bell, you just summarize your findings. So, Mrs. Smith, I've seen you today because you're in a lot of pain on your right flank. You came into hospital to have right ureteroscopy for 10mm kidney stone. Unfortunately, looking at the up notes, it looks like a left ureteroscopy was done. I've apologized that, you know, this is an error that should not have happened. I'm going to discuss with my consultants. We'll carry out a thorough investigation as to why this has happened. And we will discuss in our multidisciplinary meeting, our M&M meeting, and I will personally come and let you know the feedback, the outcome of that meeting. I have also had the duty of candor conversation with you. You have to say it. And then I'm also providing you a PALS leaflet for you to make a complaint, because it's your right to make a complaint. Whatever else you can think of that you probably did not have time to mention, just say it in the summary. Mrs. Smith, has this covered everything? You know, if there's still time to ask that question, and then that'll be the end of the station. Now, the outpatient station scenario is my favorite because it's often chilled. It often starts chilled, but it can go sideways. So again, you often have time to slowly ease into the station, make your notes. Nice, simple scenario. So a 34-year-old female has been referred to you from the GP. She's had 4 UTIs in the last 6 months. And the question is, how would you assess this patient? So within your 2 minutes, you're writing the history. You'd ask her onset, duration, progression, severity of symptoms. You've been told 4 episodes, but you want to clarify how many episodes she's had, if what symptoms she gets every time she has this UTI, is it improved with antibiotics, any triggers, is it post-sexual intercourse, is this following travel, constipation, do they have any urological history? They may be recurrent stone formers, you don't know, and then red flag symptoms. These are some things that you can note that if you think you're likely going to forget, okay, and investigations that you could ask for, you could make notes of these. So in your opening gambit, you say, I would see this patient in a general urology clinic, ideally with urinalysis on arrival. They're happy. Once you say that, they're very happy, they're relaxed. And then I would look at the referral letter. I would see if they've had any previous cultures or previous imaging or any relevant blood tests. And then I would take a focused urological history, the onset, duration, progression of symptoms, what symptoms they have, any lower abdominal pain, flank pain, fever, any hospital admissions. These are all questions you would ask anybody with current UTIs. And then red flags, say the word, I'd ask for red flags like hematuria and all that, family history, whatever else is relevant in the history. She's a female, so you want to know her last menstrual period, okay? And then any gynecological history or that's relevant. And then you would examine her in the presence of a chaperone. So you would do an abdominal examination. You're checking for any flank tenderness, suprapubic tenderness. And then if she was older, I would have done an examination of her vulva. I don't know if I would for a 34-year-old, just to check for estrogenization, but I don't know. And then, so investigations, again, you've talked about urinalysis, cultures, and then the indications for ultrasound, KUB, or flexi. If you're going to do those, then you would say you would do an ultrasound, KUB, or flexi. Now, sometimes as you say these things, they give you a response. So if you said bloods, for instance, they might say, what are you looking for in the bloods? So in this patient, you're probably just looking out for white cell count, CRP, isn't it? But take, for instance, it is a case of high pressure chronic retention or TR syndrome, and you talk about bloods. They will ask you, what do you want to know in the bloods? And then you say sodium, they give you the sodium. Potassium, they give you the potassium. Urea, they give you creatinine, you know. So if you don't say it, they won't give them to you. So if it's relevant, make sure you say the exact thing you're looking out for. Don't just wrap it out. And then, of course, treatment options often start with conservative measures like drinking lots of fluids, encouraging the patient to pass urine immediately after sexual intercourse, and then you can talk about antibiotics or treating the cause. If this is a stone, refer her to stone clinic for treatment, or antibiotics. So you could give post-coital antibiotics, you could give antibiotics prophylaxis, you can give intermittent start and stop therapy, and then they might ask you what are the non-antibiotic alternatives. So things like cranberry tablets, D-mannose, Heprex, and then they might ask you the mechanism of action of Heprex, and the question can just go wherever, or define recurrent ETI or whatever, you know. And that's why the outpatient scenarios are lovely, because it can then be a back and forth about definitions or this or that, and that can be chilled. So to summarize, preparation is key. Make sure you build your knowledge, because it gives you confidence. If you know what you're saying, you're going to come off as a confident person, and that's what they want to see. Practice makes perfect. Yes, if you don't know but you're practicing, you learn. You can become a better talker, your communication can improve. It's an exam, make sure you treat it as an exam. It's a once in a lifetime opportunity. You don't know if you're going to get shortlisted for interview again. So make sure, you know, you nail it once and for all. Be confident, but know your limits. Again, remember your ST3, and you should often discuss with your consultant. Make sure you're smiling, you're looking at the camera, relax, be calm, speak clearly, slowly, but be calm. You're a calm doctor. You know what you're doing. You've seen this before many times. It's not alien to you, so you know what you're doing. You know what you're saying, and that's all they want to see. Of course, pray if you're a religious person. Thank you. I was going to share one of the marking scheme, but the feedback I got, they all sort of mentioned the stations. So I'm sorry, I'm not able to do that without revealing the stations. But they would look at your clinical judgment, your judgment under pressure, your clinical expertise, and there's something else to look at. Situation awareness and decision making. They often look at this thing. Thank you.
Thank you very much, Anna, for that nice and enlightening presentation. I thoroughly enjoyed this, and I'm sure that's shared the same view as well. Thank you so much. So the way we would go about the question and answers would be that I would allow Habib to answer the set of questions he's got in the chat box, and same goes for Anna. I think I have 1 or 2 questions as well. So, and thanks to Ayokunle, he's helped us answer some of the questions by providing some links and some, you know, answers to some of the questions already asked. I think the first question in the chat box for Habib is the one from Mahmoud Sharif, that if we have the old certificates for CREST, can we use it? Is Habib there?
Yeah, I'm here. Thank you. So before now, they used to say it's acceptable to use the old certificate and the old CREST as evidence. But now that they've changed the CREST, I don't think it will really do any harm if you fill it again and submit this new version. So I would strongly advise that you fill the new version and you submit that one, because there's now a 2026 version. Yeah.
Okay, and then Lydia Chang has asked that for moderated poster presentations, is it enough if the certificate clearly states moderated poster presentation, or does this need to include the moderator's name?
Yeah, it's just enough to state clearly that it's a moderated poster presentation. There's no need for moderator's name.
Okay, thank you. I think some of the other questions directed towards Habib have been answered by Ayokunle in the chat box. Thank you so much for that. Yeah. So the questions directed to Anna. Mahmoud Sharif asked that, do you quote any papers for information, or would you mark? You would mark if you didn't. You would be marked down if you didn't say the actual info in the paper. He said, can I ask them to go back to the second question? Can I ask them to go back to the scenario, especially if the scenario is lengthy and I didn't catch the whole question?
Okay, yes, you could ask them to bring the scenario back on the screen. But no, we're not quitting papers for ST3. If you know it, I guess you could, but I don't think anybody would bother. It's just, yeah, like I said, you're just an SHO to them, so they don't really expect you to know papers. So I wouldn't stress about that.
Yeah, I think just to jump in and say something similar. I don't know how to put this, but I haven't spoken with some much more experienced people that have written that have done the interview. Part of what the interviewers are trying to see is if you're actually overqualified and overtrained. So they want you to answer the question as plainly as possible. If you're getting into the realms of you cutting papers every time, you need to rein it back in a bit and calm down so that you can actually be trainable. That's part of the situational awareness as part of the scoring there.
Okay, thank you, Ayo. So Mahmoud Sharif also asked that in trauma patients, do you say the whole A to E, like I will secure airways, C-spine, blah, 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 or there's no time for that?
Yeah, you could. Yeah, oftentimes. Yeah, am I? Yeah, I'm not on mute. Yeah, oftentimes when you start to say A to E, if they don't think it's relevant, they would move you along. Okay, but you can say A to E, airways pattern, breathing, SpO2 black. You could. If it's not relevant, they will just move you along.
Okay, thank you so much. If you have any other person who has further questions, we can ask them by a show of our hands. There's a link for the feedback form in the chat box. Let's kindly fill the feedback form. It helps us to improve on all of these sessions. And there are some links in the chat box as well on some YouTubes and all of that, some links and all. We can try to copy them and save them as appropriate. We would also send the slides across to the urology SIGAf page. And for those who require the slides as well, if there's a way you can reach out to any of us, I'm happy to share the slides with you. So going to the questions directed to me, I think somebody was asking what's the difference between the academic clinical fellowship and the normal urology residency program. So the academic clinical fellowship is a program whereby you would have, as part of your urology training, you would also be involved in academics and research. So the essence of that is that you would have 75% of your time dedicated for clinical activities and 25% of your time dedicated to academics and research. For the academics and research, the academic part is you undertaking a postgraduate certificate or masters of research in a university around where your clinical training is. And then the research is a research project also being conducted by a department or university close to where your clinical training is. And for the research projects, you would need to the program is actually funded by National Institute of Healthcare and Research, NIHR. So for the ACF, the application is separate. You submit an application online before the usual SC3 application opens. So that usually starts around, I think, September, October, and then you'd also be interviewed before the national interview, usually in November. So it's a separate application from the application for the ST3 itself. However, you have to be able to show that you are appointable at the national training interview. So the difference between it is that for the first 3 years of a specialty training in urology, your ACF would run within the first 3 years. So ST3, ST4, ST5 is where your ACF would run for. And it is only in that period you do 75% clinical, 25% academic. At the end of the 3rd year, if you decide to want to pursue a PhD, you can go for a PhD. And for that, you need to take time out of training, like 3 years. And then you come back to finish your ST6, ST7. If you don't decide to do a PhD, you spend 5 years just like any other trainee. However, if you decide to do a PhD, then you would have about 3 years more than the other trainees because you need to take time out for your PhD. So that's just the difference. You still have your national training number, you still do your normal training, but it's 75% of clinical and 25% of academic time, which would be within the first 3 years of your specialty training. So that's that. And then somebody asked that, what deanry is the role and what's the academic research focus in the deanry? Okay, so for my ACF is in Kent, and the clinical training is with the East Kent NHS Trust. The academic part is a postgraduate certificate in applied research method with King's College London, and the research focus is on bladder cancer, use of supramolecular self-associating amphiphiles in increasing uptake of chemotherapeutic agents by bladder cancer cells. So the research themes vary depending on what's interest, but most times they're usually on cancers. The other thing you need to notice for the ACF, for anyone interested in the ACF, you can always reach out to me privately. You can have a chat, and then I'm happy to review applications as well, because I know applications will open very soon for ACF. One thing to note is you can only apply for 3 ACF positions within an application round, and the ACFs are not usually in all deaneries. You would have it in some center. There's Kent, there's Birmingham, there is I think some in Newcastle. So you just need to check the Oriel. You see all the places where the ACFs are, and you need to pick 3 that you prefer. And one thing to note is once you get your ACF offer, when you do your national training interview, you don't need to rank or put your preference for slots or whatever. You automatically get a national training number once you get your ACF. However, you have to be part of those that have been appointable at the interview. You must pass your interview, but you don't need to score so high to be able to rank high to get a placement, because with your ACF, you automatically have a national training number. So I hope that explains everything about the ACF. The other question to Abiu that I omitted, sorry, was somebody asked that, Stephen Adekoya, how would you advise a non-CST applicant attain competencies for his CREST form and SC3 application? I think that's the last question in the chat box.
The requirement for non-UK training is just to have worked under a urology consultant here for 3 months who can certify you and tick all those boxes in the form for you. So it's just about getting someone who can vouch for you that you are at the level of ST3. You can go for ST3 application, and they'll fill this form, tick where they need to tick, and sign you off for application. That's all you require. Then the other thing will be according to this self-assessment, the question 1 to 24, and you just score yourself and see how much you've gotten. That's all you require. You need.
Okay, thank you so much, Habib. I don't know if you have any other questions. I can't see any hand being raised. So there's a link to SIGAf WhatsApp page for anyone who is interested in joining us. We run this symposium like every 3 months, and we also do regular teaching programs as well. So in November, there will be a session as well on certain things. Would bring out the poster close to the time. The other thing is, let's kindly remember to fill the feedback form. So just some other information from me as part of just my additional comments on both presentations for the next 1 or 2 minutes. So in terms of the self-assessments and portfolio and all of that, let's kindly note that as it was said, there are some conferences that are virtual conferences like ACIS Innovation Summit, GASOC, that we can submit our work to. We don't necessarily have to go physically for all the conferences because we know we don't have so much time. The other thing is between now and November, there's a lot you can do in terms of audits. So let's aim at doing short audits. We don't necessarily need to do audits of 1,000 people. We can just submit audits. The important thing is we want to make it either a single cycle or 2 cycles. So we should not look for something so massive to do. Something short that we can finish within a short period will give us the points we need. Once our supervisor is happy to sign the supervisor form. The other thing is, in terms of the marks for the presentations and the publications and all, if you have more numbers under a particular section, you can bring down, for example, you have 5 first author publications and you need just 3 to get maximum points. The remaining 2 can be brought down to non-first author. So read the self-assessment very well and understand the way the questions have been asked so you don't shortchange yourself. What I also advise is there are some things that you would think would not be accepted and would be accepted. What I would say with that is, if you have any publication at all, even if it's not PubMed index, just put it there. Put the link to their publication. One of the publications that I submitted was not PubMed index, but it was surprisingly accepted. So don't underrepresent yourself. Put everything you have. You'll be surprised as to what will be accepted, and evidences cannot be too much. The other thing with regards to the letter of leadership. Sorry, Ayo, you want to say something? Ayo, do you want to say something?
Yeah, go ahead when you're done.
Okay. Yeah. So with regards to the leadership letter, it must be in that letter that you held that position for 6 months, and must be something like medically rated or whatever. So ensure that your letter has the right content, otherwise it will not count. The other thing about the attestation letter of the teaching, it must be in that letter that teaching ran for 4 hours, and that you were the principal organizer and you did so and so. You must let the supervisor know what you want in the letter. It's not just any generic letter. You must tell them what you want to be in the letter. So it's very important. For the interviews, please, there will be a guidance on the interview that will be sent to you, talking about how you scroll through the screen for images and all of that. Please read very well and practice. I'm sure you know what. Because for my interview, maybe I got tired or whatever. I remember that I didn't scroll through all images that are displayed on the screen on one of the instrumentations. So please read the guidance sent to you, understand what you're looking out for. And then for things like X-rays and whatever, don't forget your lead jackets, stent register, and all of those. So those subtle and little things, they count. So, and finally, don't shortchange yourself. Present as many evidences as possible. You can't provide too much of evidence. So please provide as much as you can provide. So those are my additional comments. Ayo wanted to say something.
Yeah, thanks, Anna and Habib. Larry has said most of what I was going to just point out. The most important thing about self-assessment is that, remember, everything you're doing is for yourself. And as much as you need support from your senior colleagues, when you go to meet them, they will tell you about big projects that they want to do. But what you need to remember is that you need to sort all this out in a very short time. A very good example is audits, and usually you said you need two cycles to complete. But if you remember that you can do an audit retrospectively, so what I mean is that when you're auditing whatever is happening in your department, when you sit down and when you do that audit, you can look back in time, and that's your first cycle. And from the moment you've done that audit to about 1 month, that's your second cycle ongoing. So you don't have to wait the whole 6 months or 1 year in the department to do a full cycle. The second one is about the interview. Most exams in the UK, as much as they are knowledge-based, they're also quite a lot performative. So you must remember the buzzwords. You must remember to take the pause. Remember to act like you've been there. And one of the easiest way to do, because I understand not everyone is a registrar at the time. I wasn't a registrar at the time of applying. You have to go to clinics to see what happens in real life, so that it is easier for you to, just say it when you're doing interviews. And with practice, everything is going to be like, all right. It looks daunting at first when you look at everything, but if you break it down stepwise, these guys, they smashed through it in like 1 year. So it's very, very possible. Thanks everyone for joining. I'll leave Larry to conclude now.
Yeah, thank you very much. So that takes me to thanking our speakers, Mr. Rashid Habib and Ms. Anna Akpala, for the very beautiful presentations. Thanks for sharing from your wealth of experience and also talking very passionately about both the self-assessment and the interview. And I'm sure all the attendees have learned one thing or the other. A very big thanks to Ayokunle for his constant support and for ensuring that Urology SIGAf continues to break grounds. And I want to thank all those who attended as well. And I hope that you've had a wonderful time. Thank you, everyone, and have a lovely evening. Bye.
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 Bye. Thank you very much.